Good morning, everyone. Welcome to our next session in our Adult TBI webinar. I'm Dr. Jennifer Zumsteg from the Department of Rehabilitation Medicine at the University of Washington. And I'm thrilled to spend the next 45 minutes or so with you, just touching on some broad topics related to rehabilitation care and outcomes, specifically focused on moderate to severe TBI, but we can certainly talk more broadly than that. I have left it really at kind of the topical overview level for my core slides so that we can have the planned time at the end for questions and make sure that we dig into anything that's particularly interesting to the audience. Just so you have a sense of my background, I work clinically at Harborview Medical Center and have a bunch of different hats on the education side. I'm the PM&R residency program director and the brain injury medicine fellowship director and our medical director for TBI rehabilitation within the department. And I'm also board certified in brain injury medicine. We are a hospital-based rehabilitation program, which is a bit different than some other sites. And I really appreciate getting to work directly with many of the other people you're going to hear from today, but in that hospital-based setting as part of a unit in the hospital. Alrighty. So whenever we talk about rehab and outcomes, I like to start with a patient story. And this is one of my favorites to help us think as clinicians about, how would this person do? What would their outcome be after their traumatic brain injury? So this is a quote from one of their memoirs that they've shared. So to plunge or not to plunge, that was the question. This person was being bullied as a teenager, actually, and was stuck on a bridge and made the decision to jump off the bridge into a tree. And had plunged, throwing my arms out to embrace the summit of the fir tree. And it was more than 3 days before I regained consciousness and more than 3 months before I crawled from my bed. So of course I'm doing my diagnostic assessment and thinking about severity of TBI. But apparently this person fell almost 30 feet onto hard ground and commented that later when I could understand again, I had, among other things, a ruptured kidney. So also speaks to me as a clinician in terms of sometimes our ability to understand brain injury and that the other polytrauma can feel like it's taking precedent. But really a significant injury as a teenager, it sounds like, from this person's recollection. So any guesses about who this is? And it's actually Winston Churchill. And so again, I find these kinds of stories very interesting when we're thinking about outcomes and prognosis, because I would say that Winston Churchill's outcome after his TBI was just fine in terms of function. And so we'll talk much more later about how to do some broad prognosis and outcome prediction after TBI from a functional perspective, but also how we individualize that care in physical medicine and rehabilitation and the challenges in really at this point, at least, generalizing much beyond the individual care that we provide. So our learning objectives for this session are really broadly I wanted to make sure everyone knew about the TBI Model System program, and I can speak a little bit more specifically to our University of Washington program, which I'm an investigator, because there's an incredible amount of educational information for providers as well as patient educational information that can make our jobs a lot easier. We'll then look at some threshold values for functional prognosis after severe TBI. That's really the core of what right now we can say with certainty for prognosis. And it's nice to have those tools, but there are some limitations. And then talk broadly about the role of PM&R in care after TBI across the continuum of care. Not every health system has a significant number of physiatrists, and some have like here have physiatrists really embedded in all areas of care. And so with that geographic variation, I would just want to be able to open up that conversation. And then I'm, of course, happy to answer any specific questions at the end, management or education or otherwise. So really the only disclosure I have related to this talk is that I'm an investigator on the University of Washington Traumatic Brain Injury Model System grant, which is funded through the National Institute on Disability Independent Living and Rehabilitation Research. Our PI is Jeannie Hoffman, one of our rehab psychologists in our department, and I'm one of the clinical investigators. And the TBI model system awards are granted throughout the country to institutions that need to be deemed as national leaders in medical research and patient care. And it really was the first system that was implemented to provide a prospective longitudinal multi-center study that really looked at recovery and outcomes in a coordinated system after acute neurotrauma. And this is connected with the rehabilitation process. So at least right now, to be included in the model system study, you have to make it to a associated trauma center like Harborview Medical Center here or University of Washington Medical Center Hospital within 72 hours of the initial trauma, and then go directly from acute care in that system into acute inpatient rehabilitation. So that's one important thing when you're looking at some of the model system data, is that it's really focused on that course of care, including inpatient rehabilitation, which is an important piece. We certainly do offer broader educational and clinical services, and there's often other research going on, but it's a particular slice of the care pie. We are now 25 plus years into this as a large grant, and the University of Washington has been involved for most of that. And so we do now have longitudinal functional outcome and medical data for a significant number of subjects that's available nationally in the database as well. So each of the model systems contributes a core set of data to the TBI Model System National Data and Statistical Center, and during each 5-year grant cycle participates in both independent site and collaborative research, and does these other options in care, including education, continuing to work with families and caregivers in the community, as well as healthcare professionals and the public in terms of TBI services and education. If you go to the Model System Knowledge Translation Center, which actually does include resources for all of the model system programs, which are TBI, spinal cord injury, and burn. This link is specific to the TBI page. And some of the resources include really nice fact sheets that have been, peer edited and reviewed for reading level and educational content. Some of those has actually been turned into infocomics, which are a nice accessible way to have some of that information as opposed to just a very dense sheet of words, which can sometimes be a bit overwhelming. And many of the written fact sheets are also available in Spanish. Other links include kind of hot topic modules and quick reviews. There's a research database, a list of the systematic reviews that have been associated with the model system, and lots of other resources. So this is a great starting place if you're looking for information, whether it's clinical or education related. Also associated with the TBI model system projects is the establishment of the Center for Outcome Measurement and Brain Injury. It's an incredibly useful research and clinical tool for TBI scales, assessment tools related to TBI care. And it's a really nice, simple format that will give you examples of what the scales are, how to use them, the validation information, that background about were they designed in TBI or were they actually designed for something else and validated. When the tools are available in the public domain, they provide those or provide you with other links. So this is my go-to place for looking for new assessment tools or to check in on what I'm using. All right, so let's step back a little bit and look at rehabilitation care and outcomes. In terms of broad resources, just because our time is limited today, there are 2 textbooks that I think are clinically very helpful for management, and that's the brain injury medicine textbook, which is more physiatry centric, and then the silver textbook of traumatic brain injury is more of a psychiatry perspective and is very useful in I think how it presents some of the mood and personality changes associated with TBI with very practical management tips. I think it's also helpful to just kind of have useful journals on your radar. So the Journal of Head Trauma Rehabilitation and the Brain Injury Journal are good examples. And then of course, JAMA and like New England Journal and those big journals are useful resources, but just a reminder that we can also set up alerts related to topics. So for example, JAMA plus an alert for traumatic brain injury. For all of us who work in this field, making sure we don't miss those big articles that are often shifts in the paradigm of how we do care are good resources. And it's nice when our tech can make our lives a little bit easier. So Kathy Bell, who trained me always says, if you've seen one TBI, you've seen one TBI. And that's one of the things that I really find rewarding about TBI care, is how individualized and different the care and impairments and function is for each survivor. Now, this makes prognosis very challenging. And actually, in the work chapter in the Zazzler TBI book, they specifically note that because of this complexity and the unique nature of each patient with TBI, prediction of return to work for individual patients is not feasible. So that's quite a statement in our time of evidence-based practice, but I think is an honest assessment about the complexity of this problem and how difficult it is to actually come up with an algorithm within this sort of syndrome of findings that can be so different person to person. So one very useful tool that has gotten some hold is to use threshold values for functional prognosis. And we'll go through those in a little bit, but the foundation of that is really understanding some of the scales and values that were used when this was put together. So the first thing, of course, to do is to provide an initial classification of the severity of TBI. And we'll touch on this briefly, I think, just because of the lectures you've gotten so far this morning. I think later this afternoon, you'll have more on pre and in-hospital care, where there'll be, I think, additional information about the kinds of acute findings that we might need to interpret. So as many of you know, we classify the initial severity of the traumatic brain injury into mild, moderate, and severe. There's also this category that's often called mild complicated, which is typically features of a mild TBI, but with abnormal structural imaging findings. And so that's something clinically that we often use. There are different factors to use in the classification, and sometimes it depends on what's available clinically. This results in heterogeneity in the research literature, which is one of the reasons it's challenging to do more algorithmic approaches to functional prognosis after TBI. And it can also depend on what's reasonable to assess based on the comorbid injuries or medical conditions. So things we look at are structural imaging. Sometimes that can help you with specific lesion location and predictions, which we'll talk about in a moment, but there's lots of variability there in terms of severity. Loss of consciousness is important and sometimes is observed, but often is hard to get based on history. But even an estimation is more helpful than having no information. Altered consciousness or mental state, and there's an asterisk here of sort of and operationalizing what that means. And it can be everything from looking or feeling dazed to having a gap. One thing I think about with our trainees when I talk with residents is most of us are pretty sure at the end of the day whether or not we lost consciousness. So if you ask me at the end of the day, did you lose consciousness today? I should be able to say yes or no with pretty good certainty. And so as we're interviewing patients, sometimes with this altered consciousness, people will say they're not sure. And sometimes it can be that things are just so stressful and overwhelming with whatever the event was that is concerning for head injury, that it's a stress response. But there could also be this amnesia that could be brief, or it's just a small gap in time where patients are not sure if they've lost consciousness. And I think that's worth staying open to, kind of suspending our judgment about what's happened, because again, most of us are pretty sure if we've been conscious or not all day. Duration of post-traumatic amnesia is in lots of settings a little bit easier to assess and control, because you're typically looking at it after the acute resuscitation has been completed and you just have more control of the situation. The classic way, I think, to assess this is using the Galveston Orientation and Amnesia Test or the Childhood Orientation and Amnesia Test. Those are available actually through the COMPI website that I mentioned. You do have to assess over time because there can be some waxing and waning in delirium associated with TBI, and so getting a good assessment over several days is useful. And then the Glasgow Coma score is certainly an essential part of our acute injury assessment and management. This is the scale that goes from 3 to 15. 3 is the lowest score. And a GCS of 13 to 15 is consistent with mild injury. A GCS with 13 to 15, but with positive imaging findings, would be that classic mild complicated category. Moderate is the GCS of 9 to 12, and severe is 3 to 8. And so this is a challenging score to assess, but is part of many core training programs and is clinically very useful. But there's, again, that lots of heterogeneity in the research literature that's made it hard to generalize for functional prognosis. Here you'll note this is the best available score in the first 24 hours. The intent there is to understand some about if somebody is just hemodynamically unstable and needs volemic resuscitation, and that's why they're confused and not responding. We don't want to use that to just measure brain injury severity. That's a different clinical problem. So you're usually looking for best post-resuscitation GCS. And then the other challenges can be things like intoxication or other drugs that are used acutely, and that can confound our sort of cognitive assessment for folks. And really, I think understanding the clinical history associated with this for the clinical care is important. I had a recent case where the initial GCS for a patient who was hit by a motor vehicle was 15, and then over the next few days, the injury really blossomed, and there were lots of secondary injuries. And we'll talk about primary and secondary injury in a little bit, but this person has technically a mild traumatic brain injury with complications as the injury bloomed, with really severe impairments, including ended up having bilateral PCA strokes and has cortical blindness, actually had enough brain edema that they had herniation, had to have a craniectomy, just underwent cranioplasty. So these categories are meant to help us with understanding the initial classification, similar to what I would say if someone has a femur fracture, you want to know if it's displaced or not, you want to know if it's comminuted or not, and then how they heal up or whether they have residual impairments is a different discussion. And similar thing with TBI, we do need an initial classification of the severity of TBI so that we can understand, for example, if these threshold values even apply, so we can generalize the literature, so we can describe their clinical course. But it does not predict the severity of impairments that will happen later. So you could have a severe TBI like Winston Churchill and have a good functional recovery. We also certainly have patients with mild TBI who have severe headaches or post-concussive symptoms and are very functionally impaired. So the other scale that's used in threshold values is the Glasgow Outcomes Scale, and this is really selected because there's so many studies that use it, and it was one way to try to do more of a systematic review or meta-analysis with the data. So for anyone who's not familiar with it, it ranges from numerically from 1 to 5, but the category descriptors are what's most important. It includes monitoring mortality and death, as well as vegetative state, and then levels of recovery framed as disability or good recovery. So vegetative state, as you'd expect, is unable to interact with the environment and unresponsive. Severe disability is that the person is able to follow commands and do a whole range potentially of tasks, but is unable to live independently, needs assistance throughout the day where they're needing to live in an institutional or supported care setting. Moderate disability is able to live independently, but unable to return to higher level activities such as work or school. And good recovery is all of those things, plus able to return to those other life activities. So again, as we're starting to think about which categories we can generalize in the literature, we're looking at both severity of the TBI, as well as then thinking about these categories of disability for outcomes. So when we're thinking about functional prognosis for severe TBI, the most reliable thing where if you're really sitting down with a patient and their family and what can you say for sure, the most reliable thing is this idea of threshold values where you can tell people with certainty what is unlikely to happen. And this can make the language a little bit difficult because it's not either or categories where you can flip between what's unlikely and then, oh, here, what is likely to happen. You really have to stick to that messaging about what is unlikely. So if we look at the Glasgow Outcomes Scale for severe disability, that's where you're able to follow commands at least and do probably many other things. But severe disability is unable to live independently, still needs enough support, but unable to live independently. So severe disability is unlikely. It's unlikely that you won't be able to live independently if the person has time to follow commands less than 2 weeks or duration of post-traumatic amnesia less than 2 months. Okay, so that's what you could sit down and talk to with a family or a patient once they are out of their PTA and can have more of that conversation. One of the big challenges, of course, overall is if we think about these categories and also how that really plays out for patients, some of that is psychosocial factors, right? So your ability to live independently or live in a supported environment may look different depending on your financial or insurance resources or what your plan covers or whether or not you have extended family who can serve as caregivers. So there are challenges within this framework, certainly, about what's feasible for an individual person. It also really has focused on just the brain injury. So for example, you may have someone that has pretty reasonable cognitive recovery, but with their traumatic event had polytrauma and a bunch of fractures or other musculoskeletal complications. And it maybe is those issues that are limiting their ability to care for themselves or to live independently. So one grain of salt for this is really understanding for an individual patient what other factors are at play. And I should mention, this is also the summary for just non-penetrating head trauma. The studies often exclude penetrating head trauma, and that analysis was done separately. So then if we flip the other direction and say, okay, well, when can we tell patients and families that good recovery is unlikely and they need to plan for something else? We're not sure exactly what that is, but where good recovery is unlikely. So again, good recovery is not necessarily no impairments, but able to live independently and go back to other activities on their own, like work or school. Could be with accommodation, reasonable accommodation, more time for tests, etc., but able to return to most of those activities. So that is unlikely when the time to follow commands is more than 4 weeks. The duration of post-traumatic amnesia is more than 3 months, which clinically is a long time if you've worked with these folks. Also seems to be true based on age of greater than 65 years. And there's this association as well if you happen to get an MRI within the first 2 weeks of injury and there are bilateral brainstem lesions. Okay. So again, you can't tell people what is likely outside of these categories, but we can use these threshold values to sit down and say what is unlikely and that we need to plan for something different. Here's another way to summarize that. This is from the chapter in the brain injury medicine textbook. The table on your left is figure 18.6, which again, for studies of non-penetrating TBI, we look through factors such as Glasgow Coma Scale and really considered, are there trends based on those clinical factors, as well as is there a threshold value? So as you might expect with GCS, a lower score is associated with a worse functional outcome, but there's no clear threshold values. Length of coma or time to follow commands, again, longer duration generally associated with worse outcome with a threshold value that severe disability is unlikely when length of coma is less than 2 weeks, and good recovery is unlikely when it's greater than 4 weeks. That duration of post-traumatic amnesia, again, longer duration associated with worse outcomes. That threshold values include that severe disability is unlikely when it's less than 2 months. Good recovery is unlikely when greater than 3 months. For age, the older age associated with worse outcome with that threshold value of 65 years old for unlikely to have good recovery. And then neuroimaging, there are features such as the depth of the lesions that are associated with worse outcomes with those bilateral brainstem lesions on early MRI in the first 2 weeks, seeming to have a stronger threshold value. And then again, just a summary of those real threshold values of when severe disability or good recovery are unlikely using the Glasgow Outcome Scale. So given how vague that can seem to patients and families, really what we have to do on the rehabilitation side is come up with an individualized rehabilitation plan of care. And there's some ways to think through that. So one is to go back to our basic anatomy, physiology, and function, and really walk through with all of these different things that can happen with brain injury. What do we expect? What does this individual person have? what's normal, what's abnormal, what are their strengths and weaknesses, and how can we get them to their goals. So if we think about even those general categories of primary and secondary brain injury, again, I'm just reinforcing here that brain injury looks different every time. It's really, really impressive, even under similar circumstances, similar ages, similar other medical comorbidities. Every injury is different. And there's a lot of different things that can happen both at the time of injury and then days to weeks later, especially metabolically. So this is one way to think about primary and secondary brain injury. And this slide is just to remind us how complicated secondary brain injury is. There are all of these metabolic factors that play into injury and function. So really stepping back and looking at each patient and assessing their impairments is important. One framework for doing this and organizing that information is the International Classification of Functioning, Disability, and Health. This is a person-centered model to really pull in all of the things that go into a person's experience of their health, disability, function. And this is the general framework where you talk about the health condition, look at the body function and structures that are impacted, think about how that interacts with the activities that a person can and cannot do, how that impacts participation with life and community activities, and then considering those contextual features that we think about clinically, but that you may or may not have a place where you feel like those live in your assessments. And that can include environmental factors, like even literally, architectural things. Does this person now use a wheelchair and they don't have an elevator? Or personal factors, including attitudes and beliefs and other resources that may impact care. So here's some information from the CDC and WHO about this organization. On the left are what we would consider impairments with changes in body function and structure. And then here are some examples about activities and participation. These are the general categories that I'm often using in my rehabilitation assessments, as well as environmental factors that you might consider in your patient's care. When we put this together for a health condition, it can look something like this, where after a traumatic brain injury, maybe there are changes in body function and structure. For example, here, problems with visual spatial perception, mobility, power of certain muscles, muscle tone, and emotional and behavioral problems. And then the activities that impact are difficulties in changing the center of gravity of the body and impacting walking in short and long distances, even doing transfers or getting up. And then really thinking about goals and life activities, which for this sample patient is restriction of participation in their employment as a teacher and their leisure activities. You may think about environmental factors like the technology and durable medical equipment that we're going to use, such as here it's indicated as a stick, but I'm assuming they mean a mobility device like a cane. And then personal factors like age and gender and roles in life. Are they single or married or partnered? Vocational, where do they live? All of those factors. It could also include, access to insurance or other community benefits. So, we can really use this model back with our lesion location. And here's just some examples of the types of impairments that we might think about based on kind of the classically vulnerable injuries for the brain in traumatic brain injury. We know that inferior frontal lobe is very vulnerable, and there could be impairments in all of these areas, from sensory function to emotional control. And the anterior temporal lobes are also very vulnerable in traumatic brain injury. And so you can have impairments in especially semantic memory and that information processing of really the knowledge and meaning of vision and auditory and emotional sensations. So as we pull that into an individualized rehabilitation care plan, physical medicine rehabilitation is then involved in evaluation and management of all sorts of things. Here's just an example. And those can be functional goals or, back to those impairments of how do you manage those body structure and function changes. We are involved typically through all settings of care. In our system, our consultation really starts in the ICU. Some patients come to acute inpatient rehabilitation or go to subacute rehabilitation, and PM&R providers are following patients in the outpatient setting for sometimes short-term care, long-term care. Some providers will serve as primary care for persons with disabilities. And then there's certainly times where we're just serving as consultants for specific clinical questions, such as spasticity management, back to a primary care or other provider. These are the folks that you probably know as the classic rehabilitation team. These would certainly be present on an inpatient rehabilitation unit that's an IRF, and then will be variably accessible in the community depending on the program. And the physiatrist is really the leader of this interdisciplinary team to direct the medical management, prescribe interventions as needed, and to integrate that into the plan of care. And so this is really the team that leads to these amazing stories that I'm so thrilled to be a part of with our whole system of care. As some of you may know, this is Zach Lysted, who has been a strong advocate for regulation within the state of Washington, and went from his severe TBI through his rehabilitation care to now getting assessment laws in all 50 states, where children have to get assessed after any kind of brain injury. This is Zach with his parents, Vince and Mercedes, on one of their many speaking engagements. Okay. So if you have questions about PM&R, there's a lot of resources online, including our department as well as our academy. And just a reminder that there is now a brain injury medicine board certification exam if you're looking for certified providers or interested in that for your own careers. So we'll transition to questions.
All right, so we have a question on the Q&A. What are your thoughts on the Rancho Los Amigos scale? Is it useful for post-acute rehabilitation?
Yeah, so that's a great question. For the Rancho scale, for those of you who aren't familiar with it, I encourage you to Google it or look it up on the COMBI website. It's a great clinical descriptor scale. And so I find it very useful for trying to describe the current status of someone's cognitive function. So for example, you could say, this 25-year-old patient sustained a severe TBI 3 months ago and is now a Rancho Los Amigos level 4 or a level 8. And 4 would be agitated, 8 would be pretty much back to normal with maybe just a few impairments, but they're always going to have that diagnosis of a severe TBI. So the scale can be really useful for current clinical summary. I think the other piece that's important to consider is that it may be different depending on your system of care. So for example, I think in our system, we actually don't use the Rancho scale as much as we see in other systems because we're a hospital-based system and almost all of our admissions to our inpatient rehab unit are internal. And so we have access to a wide selection of clinical care. I can look at the speech note for the day. If I'm admitting them and have a question, I can actually just go see the patient as well before they come to the unit. I can see the nursing notes for how agitated they are, et cetera. If you are a freestanding rehabilitation unit, it becomes, I think, an essential part of trying to assess level of care and if someone is appropriate for acute inpatient rehabilitation or is still in coma or is still is progressed beyond the needs for an inpatient rehab facility, and can be a good summary to ask. Good, we have another question that's, where do patients and families get pointed to for chronic care when the primary physicians are not TBI educated? This seems to be a big hole in outcomes. Yes. So I think what is implied in the question is kind of like many of our catastrophic injuries, you get brought to the ER and we handle things kind of internally in acute care. And maybe you get some inpatient rehabilitation, and then what, right? Especially for these catastrophic injuries where people need chronic care over time, there is a need long-term to have that specialty involvement, especially as you know with primary care physicians who may not have seen some of these issues before. So in our system, we do expect that after inpatient rehabilitation that our patients will follow up with us in clinic, and we have everybody seen within 3 to 4 weeks after discharge. That can be a challenge for our regional system. For example, that may then be asking a patient to come back from Eastern Washington and traveling many hours to our specialty center. We find one of our program roles to continue to stay informed about local resources and in places where there are, for example, physiatrists with brain injury expertise who can take over that care closer to home. We evaluate coordinating with them. But I just got contacted by a physician in Alaska yesterday, actually, who was asking for their inpatient to come down and see us for follow-up because there's not an option in their community. I think some of it, like any consultation, it can be helpful to really define what the questions are. Or if the question is, this is so big, we don't even know what the questions are, please help us out. And so patients can be directed to different places for the resources in your system, depending on what the concerns are. So one example would be, while we really value being involved in patient care, if the only issue for someone was a headache and you did not have a TBI physiatrist in your community, then there might be some other options for headache specialists in the area, for example. And that could be a focused consultation. If there are significant mood issues, but not much else after the traumatic brain injury, then psychiatry could be an appropriate referral for that. In our system, and I think many rehab care systems, we're often trying to prioritize the patients that have multiple systems involved that really need a comprehensive integrated treatment plan. But even seeing a brain injury physiatrist once or twice a year in the more chronic scheme of things can help with, insomnia problems, spasticity management, mood management, aging with disability. And so my best advice for chronic care when primary physicians are feeling out of the loop is just to do those targeted consultations and to try to work as a team for that patient. And then we have another question about speaking more about the certification for TBI for physicians. So the American Board of Medical Specialties a few years ago started a subspecialty certification for brain injury medicine. That's the official title, so it's BIM. It is, for the most part, though, traumatic brain injury care, non-operative care. And it's through the American Board of Physical Medicine and Rehabilitation and the American Board of Neurology and Psychiatry. There are other providers who are currently board eligible for that, related to really where people do concussion care. So for example, ER and sports medicine, I believe, are currently eligible. If you Google board certification and brain injury medicine or click on that link, it'll tell you much more information. I believe there have been 2 rounds of certification exams, and I think there are about 450 subspecialty brain injury medicine board certified physicians in the US. There's another exam coming up this fall. There's also a period now where people can be board eligible by clinical experience and having that certified. So if you have a certain number of years of experience and spend at least 25% of your clinical time in care for patients with traumatic brain injury, you can have a colleague certify for that and then be eligible to sit for the exam. That has been extended through 2022, where after that, people to be eligible for the certification exam will have had to complete an ACGME accredited brain injury medicine fellowship program. There are now about 20, I think, ACGME accredited brain injury fellowship programs in the US. They just had a meeting this spring, so there might be a few more than that. And actually the University of Washington just got full accreditation or initial accreditation for our program. We have 1 brain injury medicine fellowship position each year. What other questions do we have?
So I have a question on, are there any common mistakes or maybe misconceptions would be a better term that you see commonly in relation to rehabilitation?
Sure. So I think that one thing that's often a discussion point with patients and families, but can also be very hard for other providers, is when should patients get referred to therapies like physical therapy, occupational and speech therapy, and then typically the conflicts or confusions can come around, how long should that go on? And so I think it's important to think about that those rehabilitation therapy professionals are supposed to be delivering skilled therapy. meaning they need to be using their specialty expertise and training to create an intervention and complete their work with the patient. So for example, with physical therapy, it would be appropriate to continue physical therapy for a patient where there were still goals to work on and you could demonstrate that you were maintaining or making progress on those goals, and where the time spent with the physical therapist was in skilled therapies, practicing things that needed a skilled physical therapist to do that, where like a family member couldn't just do that intuitively, or where there's training for specific compensatory strategies. So there can be that point, for example, where that physical therapy intervention turns into that the person needs to just continue to do their home exercise program. And so it's then not clinically appropriate for the patient to have, twice weekly scheduled physical therapy, to come in and have that session be the same exercise program and just doing the program and making the person accountable. So that can be a very challenging transition where people really need to be able to do their home program on their own. And it would be similar with other factors like for speech therapy, especially at about 2 years or so out. Patients will often notice a slowdown in their recovery, where we think that most of the neuroplasticity for the recovery after brain injury has occurred. And there could still be goals to work on, but they would be then usually a little bit more directed at compensatory strategies for, say, new goals, like somebody's doing a new task at work and is having trouble functionally with that. They may come back to speech therapy for a few directed sections to figure out how to compensate or adapt to that new therapy task. But just coming back to speech therapy to have an hour of productive time to, go through logic reasoning puzzles would eventually not be skilled therapy. So I think that that's one place where we often have to have kind of a heart-to-heart about what the goals of care are and what patients and families have to be able to do on their own, and find community resources to try to help support that process. That can be a gap in care. I think the other kind of missed opportunity for many people after traumatic brain injury of any severity is utilizing speech and language pathology. I think in some ways the name can make it harder to understand what they do. And our speech therapists are really our cognitive memory specialists as well. And they are the therapists, just like physical therapy. They are the brain therapists, where you would go to work on skilled therapies for cognition, memory, often even emotional control. And so I would encourage folks to think about referring to their local speech therapists for cognitive concerns early on, just like you'd refer for physical therapy if somebody was having an issue with their shoulder or their knee.
All right. And in our last couple minutes, could you tell us a little bit more about your current or recent research on TBI?
Sure. So in our last traumatic brain injury model system grant, we worked on a pilot study to look at light therapy on the inpatient rehab unit, so called Twilight. So we are currently looking at that pilot data to see what the effects of bright white light versus red light might be on many factors on the inpatient rehab unit. And then we are currently working on getting both our local and collaborative projects up and running for our new TBI Model System grant cycle. And we are looking at some really exciting things for collaborative care for pain within our clinics, as well as trying to understand the natural history of physical activity after traumatic brain injury, going from inpatient rehab out into the community. Well, thank you so much for attending. I hope you have a great rest of the session and enjoy your lunch.
Yes, we are heading to lunch, so we'll be back at 12:45.